what we're thinking about is, one, describing where children currently, the location of deaths for children, still happening primarily in hospital settings, and not only just in the hospital, but also in the ICU. And so setting up the scene with that to talk about what percentage of patients are dying at home, and basically pointing out the gap that many parents, if they had their preference and if they felt like they had adequate support, would choose for their child to die in the comfort of their homes, where it's privacy, they can have people come and go, they're surrounded by family and friends, not by the strangers in the hospital. They often are feeling like they're fulfilling an obligation to their child. So setting up that most children die in the hospital, but most parents would prefer to have them at home. We then introduce pediatric palliative transport as one of the tools that we can use. How do we get a child, again, from an ICU setting to their home? And often that means setting them up with hospice beforehand. And that often means as well just a home assessment. So like you're taking an ambulance to a patient's home. Is that in a rural setting? Is that in an urban setting? Are we going to have to work our way through narrow city streets? Or are we going out to a part where we have to think about, like, can the ambulance get through the snow? And then once you get to the house, how many steps are there up to the house? Are we taking the patient upstairs around tight corners? Like, what's sort of the home environment like? One of the interesting things is that many, particularly I think for pediatric patients, the patients are in the hospital for a long time receiving very intensive care. When it becomes obvious that the patient is nearing the end of their life, many families make a very quick decision and express, we would love to take our child home. We're often doing these conversations with a quick turnaround because the window of getting them home is actually quite narrow. Families, I think, need us in order to help explore where their preferred location of death is, and how we can make that a possibility for them. And then anything in particular that we need to consider in terms of cultural rituals, pieces that we need to do, like the little things that make it extra meaningful for the family. They need us to think about those things so that they can focus on what they need to focus on, which is being present with their child at a very sacred time. I think that's one. Second, though, I think one of the things that I've really taken away from this is one of the pieces we discovered is that providers actually, I think, feel more strongly about patients dying at home than parents do. And so we have to again step back and ask the parents what's most important to them, or the patient if the patient is old enough, because sometimes getting them home is not actually the important thing. Like, it's not just, palliative transport isn't just taking a patient from the hospital to their house. We can think about palliative transport of pediatric patients in their homes nearing the end of life, and families say, we can't do this. We can't do this at home. So I think this is a chance for us to be creative and a chance for us to be heroic in other ways, but in ways to help families honor what their hopes and their wishes are when the circumstances around them are not what they would want them to be.